Um, Welcome back to another deep dive. Today, we are heading into the hospital. We're scrubbing up and we're standing right next to the gastroenterologist.
Okay.
But we aren't just looking at the hands, the technical skill of how a procedure is done. We are looking at the brain work behind it, the logic, the
Yeah.
calculation.
It's a really fascinating area. I mean,
Yeah, I
we
know.
often think of medicine as pure action. The surgery, the scope, the
Yeah,
intervention.
it's very visual.
Exactly.
Mm.
But the real art of medicine, especially in the field like gastroenterology, is the decision-making process that happens before anyone even touches an instrument.
Right. It's like this complex mental chess game before the physical game even begins. And to guide us through this today, we are looking at a really comprehensive presentation by Dr. Gautamukala S. Raju.
Yes.
And it's all about the decision-making process behind endoscopy. He really breaks down the mental framework doctors use. It's not just, see patient, do scope. It's this intricate risk-benefit analysis.
Yeah. Right. And Dr. Raju frames this entire discussion around three massive pillars. If you want to understand medical logic, you really have to understand these three things: indications, contraindications, and adverse events.
Which is basically fancy medical speak for why do we do it, why should we absolutely not do it, and what exactly can go wrong.
Precisely. And our mission today is to decode that logic for you.
Yeah.
We want to understand how a doctor decides if you actually need that scope, when they decide it's actually too dangerous to proceed, and what specific risks are lurking in the background that you might not even think about.
So let's unpack this. We'll start with the first pillar, indications.
An indication is simply the valid medical reason for performing a procedure. It sounds simple enough.
Yeah, like I'm sick, so treat me.
Right, but Dr. Raju breaks this down into four distinct buckets. And understanding which bucket a patient falls into changes everything about how the procedure is approached.
Okay, 4 buckets of why. Let's hit bucket number 1. This is screening.
Screening is unique because, by definition, you are looking for a problem in a patient who has absolutely no symptoms.
Not at all.
Right. They feel fine. They're walking around, living their life, no complaints.
This is the person who walks in and says, "Doc, I feel great, but I just turned 45," or "My dad had colon cancer, so here I am."
That is the perfect example. A patient
Uh.
with a family history of colorectal cancer, but no bleeding, no changes in bowel habits, nothing. You're
Mhm.
looking for something silent. You are hunting for a disease before it makes a noise.
Wow.
And Dr. Raju also mentions a more specific high-stakes example here, a patient with liver cirrhosis.
Right, checking for esophageal varices.
Yes, if you have cirrhosis, which is scarring of the liver blood flow gets backed up, this pressure creates enlarged veins in the throat called varices, and they can burst and cause massive bleeding.
Like a ticking time bomb.
Exactly. So if a patient has cirrhosis but has never bled, you might do a scope to screen for these varices. You want to catch them before they become a disaster. But again, the key distinction is that the patient currently has no symptoms of that specific problem.
Got it. So screening is looking for trouble before it knocks on the door. Which brings us to bucket 2, diagnosis. This feels like the more traditional, I'm sick, help me bucket.
It is. This is when a patient walks in with a specific complaint or an abnormal sign. The investigation is driven by a clue.
So using Dr. Raju's examples, this would be the patient who comes in saying, "I'm having trouble swallowing."
Dysphagia. Exactly. If you can't swallow, we need to know why. Is it a stricture? Is it cancer? Is it just inflammation?
So the indication here is the symptom itself.
Right. Or consider rectal bleeding. You aren't screening anymore. You are hunting for the source. Is it hemorrhoids? Is it colitis? Is it a tumor?
Or even invisible clues, right? Like if a blood test comes back with low hemoglobin or a CT scan shows a weird shadow.
Correct. If a CT scan shows a thickening of the stomach wall or a blood test shows anemia, you go in to diagnose what that shadow or that blood loss actually is. You are reacting to data.
Okay, so that's screening, which is preventative, and diagnosis, which is investigative. Now, bucket 3 is where it gets nuanced, and I think this is where lay people, and honestly, maybe even some medical students, get tripped up. This is surveillance.
Yeah, people often mix this up with screening. But Dr. Raju makes a really sharp distinction here. Screening is looking for a disease you don't know exists yet. Surveillance is following up on a problem you already know about to see how it's evolving.
The example that made it click for me was the polyps.
Yes. If a patient had colon polyps removed 5 years ago and they come back today to check if new ones have grown, that is not screening. That is surveillance. You are surveilling a known history of polyps.
That makes sense. You're watching the scene of the crime, essentially.
That's a really good way to put it. You are monitoring disease progression or recurrence It changes the urgency and the specific things you are looking for.
And finally, bucket 4 is therapy, which is basically the fix-it bucket.
Right. You aren't just looking, you're doing. You know there's an esophageal stricture or narrowing of the throat, so you go in specifically to dilate it.
Yeah.
Or you place a stent. Or you remove a stone from a bile duct.
The indication isn't to find out what is this. It's to treat the problem.
Exactly.
So we have screening, diagnosis, surveillance, and therapy. That covers the why. But now we get to the part of Dr. Raju's presentation that I found really dramatic, the why not.
The contraindications. This is where the doctor has to be the brakes, not the gas.
Yeah, and Dr. Raju paints this vivid picture, almost a cinematic scene, to explain when you just cannot do the procedure, the grandmother scenario.
It's a powerful image because it highlights the core principle of a contraindication: risk versus benefit.
So walk us through it.
Imagine an elderly woman brought in by her granddaughter. She's huffing and puffing. She can barely walk across the room, and she's in severe heart failure and respiratory failure. She's physiologically fragile.
She's barely holding it together.
Exactly. In that state, severe heart and lung failure, struggling to breathe. The stress of the procedure itself could kill her. The sedation, the scope, the stimulation, it's just too much. The risk completely outweighs any possible information you might get from the scope.
It's too dangerous. Even if she needs a diagnosis, the test might be the thing that pushes her over the edge.
Precisely.
Yeah.
Her body has no reserve. And Dr. Raju lists several specific red flags like this. One that stood out to me as particularly terrifying was the unstable neck.
Oh, that sounds like a mechanical nightmare.
It is. Think about the mechanics of an upper endoscopy. To get the camera down the throat, you often have to manipulate the head, tilt the chin, open the airway.
Right.
If a patient has an unstable neck injury, like a fracture in the cervical spine, and you maneuver that endoscope, you risk displacing the bone and compressing the cervical spinal cord.
You could paralyze them.
Instantly. That is an absolute stop sign. You do not pass go.
Yikes. So unstable neck, severe heart or lung failure. What about acute events? Like if someone is actively having a stroke?
That's another major contraindication. If a patient has had an acute stroke or an acute myocardial infarction, a heart attack, you generally do not touch them with an elective scope.
Because their body is already in crisis mode.
Right. They are in a cytokine storm. They are inflamed, stressed.
You have to let the fire put itself out before you go in to check the plumbing.
In a manner of speaking, yes. The same goes for active seizures or hemodynamic instability.
Which is medical speak for shock or incredibly unstable blood pressure.
Yes. If the patient is crashing, you don't scope them unless it's absolutely life-saving right that second. Sedation usually lowers blood pressure, so if they're already low, you could bottom them out completely.
And there was a note about blood, too, like if the blood itself is broken?
Yes. Severe anemia or coagulopathy. If the hemoglobin is extremely low, or the platelets, which help blood clot, are too low, or the white cell count is gone, doing a procedure that might cause bleeding is incredibly risky then. You can't make a cut if the body can't form a scab.
But, and here is where it gets really interesting, Dr. Raju clarifies that no doesn't always mean never.
This is the critical concept of optimization. A contraindication might be temporary. It might be relative.
Right. He talked about fixing the patient first.
Exactly. If the patient has unstable blood pressure, you stabilize it with medication. If they have an infection, you treat it. If they're in heart failure, you manage the fluid with diuretics. You can turn a high-risk patient into a moderate-risk patient.
Well, optimize them.
Yes. Once the risks are lowered, the calculation changes, and you might proceed. It's not a hard wall. It's a hurdle you have to clear. The goal is always to get the patient to a place where the benefit finally outweighs the risk.
Okay, so we've decided we can do the procedure. We've cleared the indications. We've dodged the contraindications. We've optimized the patient. Now we're in the room. The lights are dim. The scope is ready. But things can still go wrong.
Oh, absolutely.
This brings us to the third pillar, adverse events.
And Dr. Raju divides these risks into two very distinct camps, which is a helpful way to think about it. There are the risks of the sleep and the risks of the scope.
Meaning anesthesia versus the procedure itself.
Correct. The first set of risks comes from putting the patient under sedation. The anesthesiologist has to manage the heart and the lungs.
What are the big worries there?
The heart is a major one. Sedation can cause arrhythmias, irregular heartbeats. It can cause hypotension, which is low blood pressure, or even hypertension. But the respiratory issues are often the most immediate concern.
Hypoxemia, right, low oxygen.
Yes. And specifically, aspiration. This is a mechanism worth explaining. Normally, when you are awake, you have reflexes. If you swallow, your glottis closes to protect your lungs. If something goes down the wrong pipe, it cough.
Right, the body protects itself.
But under sedation, those reflexes are blunted or gone. The patient cannot protect their own airway. So if there are secretions or fluid in the stomach, they can slide up the esophagus and down into the lungs. That is aspiration.
And stomach acid in the lungs sounds like bad news.
It's devastating. It causes chemical burns and pneumonia. That is a major anesthesia risk.
Okay, so that's the sleep risk. Now the scope risk. This is what the gastroenterologist is sweating over.
The big two are bleeding and perforation.
Bleeding seems obvious if you're cutting things out, like polyps.
Exactly. Whether you are removing a polyp, dilating a stricture, or cutting a sphincter, you are wounding tissue. Bleeding is a constant risk. But perforation, that is the one everyone fears.
Poking a hole.
Poking a hole through the wall of the bowel, stomach, or esophagus. Now you have bacteria leaking into the abdominal cavity. It's a surgical emergency. But Dr. Raju also mentions a fascinating specific injury regarding organ damage, splenic rupture during colonoscopy.
The spleen. I always thought the spleen was way up high, tucked under the ribs. How do you hit that during a colonoscopy?
It is up high. And usually you don't hit it directly. That's what makes this wrist so tricky. The colon has a bend called the splenic flexure that loops right past the spleen.
Oh, I see.
There are ligaments, connective tissue, tethering the colon to the spleen. If the colonoscopy is difficult, or the scope forms a loop and creates tension, you can actually pull on those ligaments.
So you're not poking the spleen, you're yanking on it from the inside.
Exactly. You cause traction injury. You can tear the capsule of the spleen without ever touching it with the scope, just by pulling on the colon attachments. It's rare, but it is dangerous because it causes internal bleeding.
That is wild. It really shows how connected everything is inside. And there was one more risk he mentioned, which I found surprisingly humble. The mist problem.
Yes, the risk of simply not seeing what is there, overlooking a lesion. It's an adverse event, not because you hurt the patient physically in the moment, but because you failed to diagnose them.
You did the procedure, but you missed the cancer.
Precisely. That is a very real risk inherent to the human element of medicine. It creates a false sense of security for the patient. They think they are clear, but the problem is still there.
It's a sobering thought. You can do everything right technically and still miss the target.
Which is why vigilance is the most important skill a doctor can have.
So let's say the procedure is done. The patient wakes up. They're groggy but smiling. They go home. High fives all around.
Not quite. And this is the fourth section of our deep dive, and maybe the most practical for you listening, the 30-day watch.
I was surprised by the timeline. Dr. Raju says the danger zone isn't just the recovery room. Patients are told to watch for symptoms for up to 30 days.
That's right. Some complications are immediate, but others simmer.
So what are we looking for? What's on the "if this happens, call us immediately" list?
The general signs are what you'd expect: bleeding, severe pain, fever, cough, shortness of breath. But Dr. Raju goes into the why behind these specific symptoms. The symptom actually tells you exactly what went wrong.
Let's break those down. He talked about aspiration pneumonia again here.
Right, remember we talked about aspiration risk during anesthesia. Well, if that happens, if fluid went into the lungs, the patient might not realize it until they get home. The bacteria take time to grow.
So a few days later,
They develop shortness of breath, a fever, low oxygen saturation. You take a chest x-ray and you see white shadows in the lungs. That's the aspiration manifesting days later.
then there's bleeding. And he used some very specific terms here that are worth defining because they tell you where the blood is coming from.
Yes. There's hematemesis, which is vomiting blood. That usually means active bleeding in the upper stomach or esophagus. It's coming from the top. Then there's hematochezia, which is passing bright red blood from the rectum.
Which usually means the bleeding is lower down near the exit, or it's so massive it's rushing through.
Correct. And then there's melena. This is dark, black, turry stool.
Black stool. That means the blood has been digested.
Exactly. It's older blood traveling from higher up in the tract. As it moves through the intestines, digestive enzymes turn it black and sticky. So if you see that, you look for a source in the stomach or upper small intestine.
And he also mentions syncope, which is dizziness or fainting.
That's a sign that the patient has lost so much blood volume that their brain isn't getting enough oxygen.
So if you faint after a colonoscopy, that's a huge red flag.
Huge. It means your hemoglobin is dropping and your kidneys might even take a hit from the lack of blood flow. It's a systemic crisis.
Okay, next up is perforation, the hole in the gut. How does a patient know they have that once they're home?
It depends on where the hole is. If it's an esophageal perforation like after a dilation, the patient will have severe retrosternal chest pain, pain right behind the breastbone.
And on an X-ray, you might see air around the heart.
Pneumomediastinum, yes, air shouldn't be there. If the X-ray is clear but you're still suspicious, you get a CT scan.
What about lower down, a hole in the stomach or colon?
Abdominal pain, fever, and signs of sepsis. The bacteria from the gut is leaking into the body. An upright X-ray might show air under the diaphragm. That's the classic sign of a perforated bowel, free air in the abdomen.
Got it. And Dr. Raju also brought up pancreatitis, right?
Yes, specifically after procedures like an ERCP, which looks at the bile and pancreatic ducts, or a fine needle aspiration.
What are the signs of that?
If a patient develops pancreatitis, they'll experience severe abdominal pain, nausea, and vomiting, and if you run blood work, you'll see elevated amylase and lipase enzymes. The pancreas gets inflamed from the manipulation.
And finally, the one that connects back to that weird injury we discussed earlier, splenic rupture. This one sounded almost like a magic trick. The pain shows up in the wrong place.
It's called referred pain. A patient goes home after a colonoscopy and starts feeling abdominal pain, but also pain in their left shoulder.
Left shoulder pain.
Yes. The bleeding spleen irritates the diaphragm, which is right on top of it. The nerves that supply the diaphragm share the same root as the nerves that supply the shoulder skin, so the brain gets confused and refers the pain to the shoulder.
That is such a specific detective-like detail. If a patient calls with belly pain and left shoulder pain after a colonoscopy, you have to think about the spleen.
You absolutely have to. It really shows how everything is connected. The body gives clues if you know how to listen.
So we've gone from the initial, why do we do this, to the why shouldn't we, to the risks during the procedure, and finally the warning signs after going home.
It's a full life cycle of medical decision-making.
It really changes how I look at these procedures. It's not just a checklist. It's a constant balancing act.
That is the key takeaway. Medicine is about weighing risks. Is the risk of missing the cancer greater than the risk of the sedation? Is the risk of the bleeding greater than the benefit of the diagnosis?
And listening to Dr. Raju's insights, you really get the sense that the best doctors are the ones who are constantly reevaluating that balance.
Absolutely. The decision to not do a procedure is often harder and more important than the decision to do one. Waiting for a stroke to stabilize or optimizing a heart failure patient, that requires immense patience and judgment.
It brings us back to that idea of the missed lesion, too.
Yeah.
It's a reminder that even with all this technology and all this logic, there's a human element.
We are fallible. The procedure can be technically perfect. No perforation, no bleeding, stable vitals. But if the eye misses the polyp, the mission failed.
It really invites you to think about vigilance, not just for the doctors, but for us as patients. Understanding that a successful procedure doesn't just mean waking up. It means understanding what was looked for, what was found, and what we still need to watch out for.
Critical thinking is the best tool in the medical bag.
It leaves you with a provocative thought, though. If the logic of indications and contraindications is so perfect, but the human execution is still flawed, like missing a lesion, what does the future look like? Will AI eventually be the one watching the screen to eliminate that human error? It really makes you wonder how much of this mental chess game will always require a human mind.
It's a fascinating question for the future of medicine.
Well, on that note, we're going to wrap up this deep dive. A huge thank you to the insights from Dr. Raju's presentation. It's giving us a lot to digest.
Indeed, it's a heavy meal.
Thanks for listening, everyone. Stay curious, stay healthy, and we'll see you on the next deep dive.